Did you know that every 6 minutes a senior suffers a stroke that could have been prevented? This isn't just a chilling statistic, it's a wake-up call. Today we're going to talk about a silent threat, one that many people carry in their pockets or store in their bathroom cabinets. Common medications, prescribed with good intentions that may be tripling the risk of a stroke, also known as a cerebrovascular accident or CVA. If you're over 60 or care for someone who is, this video could literally change your life. What I'm about to share isn't theory, it's science backed by recent studies. 4 classes of medications used daily in millions of homes are creating a perfect storm in vulnerable aging brains. And the worst part, almost no one is talking about it. So let me ask you directly, what would you do if you found out a medication you take every day might be the trigger for a stroke? Would you keep taking it without asking questions? Wait until something happens? This video isn't about fear, it's about giving you the power to decide with knowledge in hand. Before we dive in, let's quickly understand what a stroke is. Picture your brain as a bustling city. Its highways are arteries that deliver oxygen and nutrients to every neighborhood of neurons. When one of those highways gets blocked or bursts, a stroke happens. It can be ischemic, caused by a clot that stops blood flow, or hemorrhagic, when a vessel ruptures and floods the brain. In both cases, time is life. Every second without oxygen kills millions of neurons. And here's the stat that froze my blood. Some common medications can triple the chance of this happening. It's not being said loudly, but clinical research and health agencies are already warning us. These are drugs that raise blood pressure, alter blood flow, thicken the blood, or block critical brain functions. We're not talking about illegal substances, we're talking about pills you might have at home right now. You might think that just because something is prescribed, it must be completely safe. But the truth is, many of these medications were approved decades ago, before we fully understood the aging brain. New research is revealing side effects that went unnoticed, especially in older adults, and we need to talk about it now. You might be thinking, but if a doctor gave it to me, it must be fine. The reality is, even well-meaning professionals may not always stay updated on every new risk profile, especially with medications that have been considered routine for years. That's why it's crucial that you, the patient or caregiver, feel empowered to ask questions and seek alternatives. In the next few minutes, we're going to open that medicine cabinet with a scientific flashlight. We'll identify the 4 culprits, explain exactly how they work, why they're dangerous, and what you can do about them. And let me say up front, the last group of drugs is the most alarming because of how widely they're used, the damage they cause, and how casually they're prescribed without a proper risk assessment. Stay with me until the end because I won't just tell you which drugs to look out for, I'll also show you safer alternatives and what questions to ask your doctor right away. This video isn't a warning, it's a tool. And you, whether you're a patient or caregiver, deserve to have all the facts. Let's begin. 1. NSAIDs, the common painkillers with hidden dangers. Non-steroidal anti-inflammatory drugs, known as NSAIDs, are among the most commonly used medications in the world. Ibuprofen, naproxen, diclofenac, familiar names, easily accessible, many available without a prescription. They're used to relieve pain, reduce fever, and treat inflammation. They seem harmless, even routine. But in older adults, frequent use carries a far greater risk than most realize. Science is clear, NSAIDs can triple the risk of a stroke. Why? Because their effect goes far beyond short-term relief. The first danger mechanism is elevated blood pressure. NSAIDs cause sodium and water retention, which increases blood volume. At the same time, they stiffen the arteries. The result is silent hypertension, especially dangerous in people with cardiovascular history. And as you may know, high blood pressure is the #1 risk factor for stroke. The second mechanism directly affects the kidneys. These drugs reduce blood flow to the nephrons, the body's natural filters. A compromised kidney worsens blood pressure and can lead to toxin buildup that impairs brain function. NSAIDs also interfere with platelets, disrupting blood clotting. This can promote clot formation in the wrong places, like the arteries of the brain. The third mechanism is even more insidious: vascular inflammation. Chronic NSAID use causes ongoing inflammation in the endothelium, the inner lining of blood vessels. This inflammation leads to the buildup of atherosclerotic plaques, fatty deposits of cholesterol. If one of those plaques breaks loose, it can travel through the bloodstream and block a brain artery. The result? An ischemic stroke. Recent studies, such as those published by the British Medical Journal and the European Heart Journal, have shown that in people over 65, regular use of NSAIDs increases stroke risk by more than. This risk doubles if the person already has hypertension, diabetes, or a history of cerebrovascular events. Even more concerning, many older patients take them daily for years to manage conditions like osteoarthritis, often without knowing the long-term effects. So what should you do? The first step is not to panic, but to act wisely. Never stop taking any medication suddenly without consulting your doctor. The ideal course of action is to review with your healthcare provider whether the NSAID is truly necessary and what the lowest effective dose would be. Often it can be replaced with less risky options. For example, acetaminophen doesn't raise blood pressure or interfere with clotting. While it's less effective as an anti-inflammatory, it can still help with mild or moderate pain. Another option is using NSAIDs in topical forms like creams or gels. These work locally and reduce systemic effects. Studies show that a diclofenac gel applied to a joint can be as effective as a pill with less cardiovascular risk. Non-drug treatments should also be considered. Physical therapy, targeted exercise, heat and cold therapy, acupuncture, and relaxation techniques can all help reduce chronic pain. A multidisciplinary approach that combines several strategies often yields better results than relying solely on pills. It's also essential to educate patients and caregivers on the difference between immediate pain relief and long-term health. Many older adults believe that if something relieves pain, it must be safe, without realizing the cumulative toll it can take on the heart, kidneys, and brain. That mindset must change. Empowering patients with knowledge is part of modern care. Healthcare providers should also use risk assessment tools like frailty scales, cardiovascular evaluations, and routine blood pressure monitoring to determine who might safely use NSAIDs. If an older adult has multiple risk factors, priority should be given to exploring safer alternatives. Routine checkups are crucial when NSAIDs are part of long-term treatment in older adults. Even seemingly mild symptoms like fatigue, mild confusion, or ankle swelling can signal underlying vascular strain. Regular lab tests to monitor kidney function, blood pressure logs, and follow-ups with a healthcare provider can detect early warning signs before they escalate. Another essential aspect is open communication between patients and providers. Seniors should feel empowered to ask, "Is this the safest option for me given my age and health conditions?" That question alone can shift the course of treatment toward a safer path. It's also important for family members to stay informed and engaged in these decisions, especially if the older adult has cognitive limitations. A shared decision-making approach ensures that medication choices align with long-term goals, preserving independence, preventing cognitive decline, and maintaining quality of life. Medication should support those goals, not compromise them. In summary, NSAIDs are not inherently dangerous, but in older adults, they must be handled with extreme care. Being proactive, asking questions, reviewing prescriptions, considering alternatives can prevent irreversible harm. Stroke prevention doesn't always start in the ER. Sometimes it starts in your bathroom cabinet with a conversation and a decision to be informed and cautious. 2. Anticholinergics, a hidden risk to brain health. Anticholinergics are a class of medications designed to block the action of acetylcholine, a key neurotransmitter involved in multiple bodily functions. They're widely used to treat conditions such as overactive bladder, urinary incontinence, some gastrointestinal issues, and in certain cases, allergies or respiratory disorders. It all sounds useful until we consider the effects on older adults. For this group, these medications pose a hidden and serious risk to brain health. Acetylcholine isn't just involved in muscle control. It's crucial for brain function, especially memory, learning, focus, and alertness. When anticholinergics block acetylcholine, they directly impair these cognitive processes. And in aging brains where acetylcholine production is already lower, the impact is even greater. Common examples include oxybutynin, tolterodine, sulfanicin, and darafenacin. These are frequently prescribed to help control urinary urgency or prevent leakage. However, multiple studies have linked prolonged use to accelerated cognitive decline, significantly higher rates of dementia, and a clear increase in stroke risk. A meta-analysis published in JAMA Neurology found that continuous use of anticholinergics increases the risk of dementia in older adults by 50%. What's more troubling is that even low doses over short periods can begin to impact cognitive health, especially when combined with other medications with anticholinergic properties. From a vascular perspective, these drugs disrupt the brain's ability to regulate blood flow. Acetylcholine plays a key role in dilating cerebral vessels. When blocked, the brain may struggle to adjust blood supply during high demand, setting the stage for silent ischemia or even a full-blown stroke. Side effects like drowsiness, blurred vision, dizziness upon standing, and confusion not only reduce quality of life but also increase the risk of falls, injuries, and hospitalizations. What seems like a minor symptom may actually signal something more serious. One major concern is that many anticholinergics aren't clearly labeled. They can be found in combination cold medicines, allergy treatments, and older antidepressants. This means an older adult might unknowingly be taking several anticholinergic agents each day, compounding their risk. What can we do? First, review every medication an older adult is taking. Tools like the anticholinergic burden scale help assess overall exposure and flag high-risk combinations. If the total burden is high, it's crucial to discuss safer alternatives with a doctor. For bladder issues, newer medications like beta-3 agonists such as mirabegron act via different mechanisms and have significantly fewer cognitive side effects. Though not without risks, they are often a safer first-line option for seniors. Non-drug interventions also matter. Pelvic floor exercises, bladder training, hydration adjustments, and even reducing caffeine and alcohol can provide noticeable improvement. A personalized, holistic strategy is more effective and less risky than simply adding another pill. The key is communication. Every patient or caregiver should ask their doctor, does this drug have anticholinergic effects? Are there safer options? That single question can trigger a shift towards safer treatment. Many symptoms we attribute to aging, like memory lapses, slow thinking, or mental fog, could actually be drug-related. Being informed gives us a critical advantage in promoting healthy aging. Medication reviews should be a regular part of care, especially for older adults taking multiple prescriptions. Geriatricians and clinical pharmacists can help detect dangerous combinations and make safer substitutions. Providers must stay updated on new evidence and always weigh the neurological and vascular risks before prescribing anticholinergics. Clinicians must also be aware of the cumulative impact of prescribing habits. Often, a patient starts with one medication and over time, additional prescriptions are added to manage side effects, many of which stem from the original drug's anticholinergic properties. This cascade effect leads to polypharmacy, which exponentially raises the risk of adverse outcomes, including stroke. To avoid this, the prescribing should become a standard part of geriatric care. The prescribing involves systematically reducing or discontinuing medications that may no longer be necessary or that pose more risk than benefit. It's a patient-centered process that prioritizes long-term safety and functional independence. Caregivers can play a vital role in this process. By observing and documenting changes in cognition, mood, mobility, or alertness, they can provide valuable insights to healthcare providers. Their advocacy is especially important when the patient has difficulty articulating symptoms or remembering medication details. Finally, public awareness campaigns are needed to inform communities about the hidden risks of anticholinergic medications. Educational efforts can empower families to ask the right questions and push for safer, evidence-based approaches to managing chronic conditions in older adults. The path to safer aging isn't always about new treatments, it's often about re-evaluating the ones we've trusted for too long. 3. Corticosteroids. The relief that comes at a cost. Systemic corticosteroids, such as prednisone and dexamethasone, are powerful medications used to treat a wide range of inflammatory and autoimmune conditions, from asthma to rheumatoid arthritis, from severe allergic reactions to chronic respiratory diseases like COPD. Their anti-inflammatory effect can be almost immediate. But like many powerful drugs, that benefit comes with significant side effects, especially when used long-term. In older adults, chronic corticosteroid use is strongly associated with an increased risk of stroke. Their widespread impact on cardiovascular and metabolic systems can become dangerous if not closely monitored and managed over time. One of the first concerning effects is elevated blood pressure. Corticosteroids cause the body to retain sodium and water, increasing blood volume. They also deplete potassium, which is vital for heart function. This combination creates a fertile ground for persistent hypertension, a silent threat to the aging brain. Another major issue is high blood sugar. Corticosteroids raise glucose levels by interfering with insulin. In predisposed individuals, this can trigger type 2 diabetes or worsen existing diabetes. Chronically elevated blood sugar damages blood vessels, making them more fragile and inflamed, factors that heighten the likelihood of stroke. A third mechanism involves lipid imbalance. Corticosteroids tend to increase LDL bad cholesterol while decreasing HDL good cholesterol. This accelerates the formation of atherosclerotic plaques, which can block cerebral arteries or break off and travel to the brain. When combined with high blood pressure and elevated glucose, the stage is set for an ischemic stroke. Some studies also suggest corticosteroids may make the blood more viscous, increasing the risk of clot formation. While this procoagulant effect is less well known, it becomes more dangerous in the presence of other stroke risk factors. Research published in journals like Stroke and The Lancet supports these concerns. Older patients on long-term corticosteroids face up to a 60% higher risk of stroke compared to non-users, especially when treatment exceeds 12 weeks or involves high doses without a clear tapering strategy. The biggest problem? Lack of a long-term plan. Many patients begin corticosteroids during a crisis but continue for months or years without reevaluating their need or considering alternatives. That extended use without careful follow-up turns a life-saving drug into a long-term threat. What can be done? First, corticosteroids should never be stopped abruptly. Doing so can trigger adrenal insufficiency, which is potentially life-threatening. Tapering must be done gradually and always under medical supervision. However, periodic reassessment is essential. Every doctor's visit should include the question, "Do I still need this dose? Or can it be reduced?" In many cases, alternatives exist. For example, in asthma or COPD, inhaled corticosteroids provide localized relief with fewer systemic side effects. For inflammatory conditions like arthritis, disease-modifying drugs such as methotrexate can reduce or eliminate the need for oral steroids. It's also critical to implement protective measures. That means strict control of blood pressure, glucose, and cholesterol. It also involves lifestyle changes. A diet low in salt and sugar, regular age-appropriate physical activity, and frequent monitoring of kidney and liver function. These steps can help counterbalance the risks of steroid treatment. The healthcare team plays a key role. Primary care doctors, specialists, and pharmacists must work together to build a dynamic, long-term treatment plan. Medication education is equally important. Patients should know what the drug is for, its risks, and how to minimize them. Ongoing clinical follow-up is not a luxury, it's a vital necessity. Many corticosteroid side effects can be caught early and corrected through simple adjustments. That's why it's critical to attend scheduled checkups, keep up with lab tests, and report any new or unusual symptoms. Most importantly, no medication should be considered permanent without periodic review. In aging populations, ongoing vigilance makes the difference between functional independence and long-term disability. One often overlooked factor is the psychological impact of long-term corticosteroid use. Patients may experience mood swings, anxiety, irritability, or even symptoms of depression. These effects not only impact emotional well-being but can also interfere with treatment adherence and quality of life. Older adults may be less likely to report these symptoms, attributing them to age or illness, making proactive monitoring all the more important. It's equally essential to involve caregivers in the management process. They can observe day-to-day changes and help ensure medications are taken as prescribed. Their input is invaluable when evaluating whether the treatment is improving quality of life or introducing new risks. Clinicians should also document and communicate a clear steroid exit plan from the outset. Every corticosteroid prescription should come with a plan for reassessment and tapering if possible. This mindset promotes a culture of safety and prevents long-term dependency by default. Ultimately, the goal isn't to avoid corticosteroids altogether, but to use them intelligently with precision, caution, and a plan. When managed properly, these medications can be life-saving. When ignored or prolonged without scrutiny, they become a silent threat to vascular and cognitive health. 4. Antipsychotics, a risky shortcut in dementia care. Antipsychotics were originally developed to treat severe psychiatric disorders such as schizophrenia, bipolar disorder, and acute psychosis. Drugs like risperidone, olanzapine, and quetiapine target brain chemicals like dopamine and serotonin to manage hallucinations, delusions, and extreme behaviors. In those cases, they can be life-saving. But increasingly, these powerful drugs are being prescribed to a much more vulnerable population, elderly patients with dementia. This shift in use is understandable but dangerous. Many people with advanced Alzheimer's or other dementias experience difficult behavioral symptoms like agitation, aggression, hallucinations, or severe anxiety. In busy healthcare systems with limited staff and support, antipsychotics have become a go-to solution to manage these behaviors quickly. However, this shortcut comes with serious risks. Multiple studies and health authorities have raised red flags. The U.S. Food and Drug Administration (FDA) has issued its strongest warning, a black box warning stating that using antipsychotics in elderly dementia patients significantly increases the risk of death. One of the main causes of that increased mortality is stroke. Why? First, antipsychotics can cause orthostatic hypotension, a sudden drop in blood pressure when standing up. This disrupts cerebral blood flow and can lead to dizziness, fainting, or transient ischemic attacks. Repeated episodes can cause cumulative microdamage in the brain, increasing stroke risk. Second, antipsychotics can disrupt heart rhythms, triggering arrhythmias such as atrial fibrillation, which can lead to clots traveling to the brain. For seniors with existing heart issues, this adds another layer of danger. Third, many antipsychotics cause severe metabolic effects. Drugs like olanzapine can lead to rapid weight gain, high cholesterol, and insulin resistance. Within weeks, a person may develop high blood sugar and blood pressure, both major risk factors for stroke. There's also growing evidence that antipsychotics may increase blood viscosity and promote a hypercoagulable state, making blood more likely to form clots. In a vulnerable brain, this is an extremely dangerous combination. Altogether, these effects make the link between antipsychotic use and stroke in seniors very real. Research published in journals like Neurology and the Journal of the American Geriatrics Society shows that older adults with dementia taking antipsychotics have up to triple the stroke risk compared to those not taking them. So what can we do when a dementia patient shows challenging behaviors? First, identify the root cause. Many times, agitation or aggression stems from an unmet need, pain, a urinary infection, fear, or environmental changes. Addressing these issues can significantly reduce symptoms without medication. Non-drug interventions should always come first. Environmental modifications, clear routines, therapeutic music, physical activity, and validation techniques can be incredibly effective. These approaches take time and patience, but they are safer and more respectful to the patient. When antipsychotics are truly necessary, for instance, when the patient is a danger to themselves or others, they must be used with extreme caution. Lowest effective dose, close monitoring, limited duration, and a plan to taper off. Informed consent from the patient or legal representative is essential. Caregivers are key allies in this process. They often notice subtle changes and side effects that clinicians might miss. Their observations and advocacy can help ensure medications are used responsibly or avoided altogether. Healthcare systems also have a responsibility to invest in dementia care training, hire specialized staff, and promote policies that favor non-pharmacological solutions. Treating behavioral symptoms with empathy and structure rather than sedation must become the norm. Doctors must document a clear plan whenever an antipsychotic is introduced. This includes defining the target symptom, setting a timeline for reevaluation, and having a tapering strategy from the outset. Medications should never be prescribed indefinitely without frequent reviews of risks and benefits. Pharmacists also play a crucial role. They can flag high-risk prescriptions, suggest safer alternatives, and provide education to caregivers on potential side effects. Interdisciplinary collaboration between physicians, pharmacists, and nurses ensures that decisions are guided by the patient's overall well-being, not convenience. Public awareness is equally important. Families must be encouraged to speak up, ask questions, and explore behavioral therapies before accepting prescriptions. Education campaigns can help normalize the idea that managing dementia requires more than just medication. It requires time, empathy, and support. Ultimately, antipsychotic use in elderly dementia patients must shift from being routine to being exceptional. When used, they must be monitored with the highest standards, and when avoided, patients often thrive under more humane, attentive care models. Every stroke prevented means preserving memory, independence, and dignity. And that's a goal worth working for in every home, hospital, and care facility. We've just explored 4 groups of medications that, while often prescribed to help, can pose a serious threat to the aging brain. NSAIDs, anticholinergics, corticosteroids, and antipsychotics all serve important roles in medicine, but in older adults, they come with risks that are too often overlooked. The goal of this video isn't to scare you, it's to empower you. Now you know what many still don't, that a common pill taken daily can increase your stroke risk dramatically. But more importantly, you also know what questions to ask, what warning signs to look for, and what safer options may exist. Information is your greatest ally. Review your medications. Speak with your doctor, and don't be afraid to challenge prescriptions that may no longer serve you well. Be respectful, but be firm. Your brain, your independence, your future, they're worth it. If this video helped you, don't keep it to yourself. Share it with someone who needs it. You could be preventing an emergency, a life-altering condition, or even saving a life. And if you haven't already, hit that subscribe button and turn on notifications. Knowledge isn't just power, it's protection.